Hello. Hello.
Right. Good morning. Hello.
Oh,
Yeah, good morning.
good morning.
All right. So we have a very short topic today, and I don't know. I think still the network is still not on point. So who is the class captain for today's class? I want to know if it's okay for us to start. Hello. Hello.
Hello.
Yeah. Please, can we start?
Yeah, I think we can start. It was Nana was hosting the meeting, but I don't think he's available right now. So.
Okay. So we have a very short topic today, so let's try and then finish it early. Okay, so today's topic will be nausea, vomiting, one of those general topics. In so many conditions, pathogenic as well as infectious agents, even pregnancy can result in nausea and vomiting. So it's common with several conditions. And how does it happen? How do we handle it? Let's try and then quickly look at it. Then next week, we will shift to either respiratory or infectious. So nausea, vomiting. Class captain. So you are the host now, eh?
No, but
Okay, because from time to time I will ask whether I'm still online or not.
okay, I think I can
Please
do
try
that.
and then respond. Okay, all right. Okay, so when we say nausea, vomiting, what does it actually mean? Technically, as we all know, vomiting is also called emesis. So that is the actual act that results in the movement of the GI contact through the esophagus through the mouth and outside the body. Normally, just before you vomit, one may feel some unpleasant sensation, and that is what is referred to as nausea. At times, too, the nausea will happen, but no, vomiting will not follow. At times, you will not feel any nausea, but all of a sudden, you vomit. These two factors are not always bad. We know that, yes, vomiting can lead to so many complications, but they are not always bad, simply because in most cases, they tend to help remove harmful substances that, if are absorbed into the systemic circulation, will cause harmful effects. Vomiting will help to remove all these agents through the mouth to outside the body and minimize or prevent their absorption. If you take some poisonous agents and you are lucky, vomit, it will reduce the absorption of the poison. At times, even certain drugs, certain food substances that you can't tolerate, your body just can't tolerate. Vomiting may help you remove such substances from your body. It normally occurs through three main acts, three main steps. The first one is the pre-ejection of the vomitus outside the body, that phase. Then retching will follow, and then finally the actual act of vomiting will happen. So let's look at these three. Pre-ejection phase of vomiting. We all know that in the GIT we have peristaltic movement that always starts from the esophagus, move through the stomach, down all the way to the anus. That is forward peristalsis. Just like a moving car, if a car is going forward and wants to do a reverse, the car can't suddenly reverse whilst going in the forward direction. The car will have to stop, then you change into a reverse gear, then you do backward movement. Same happens in vomiting. Originally, the GIT will be doing forward peristalsis. And for vomiting to occur, you should have the GIT moving in the opposite direction, that is retro peristalsis. This can just suddenly happen when there is forward peristalsis. Therefore, the GIT will have to relax before the backward movement will occur. So with the pre-ejection phase, there is always gastric relaxation, followed by the backward movement of the GIT, retroperistalsis. After the pre-ejection phase, there comes retching phase. So retching is where you have rhythmic respiratory muscles contractions. And within the retching phase, another good thing that protects us from harming ourselves is closing the airway with the epiglottis. So you have the airway being closed, because if the vomitus is coming and the airway is open, and you can have some of the vomitus passing into the airways, and possibly the person can suffer from issues like aspiration pneumonia. So before the vomitus comes out, there is a phase of retching, which involves the rhythmic action of the respiratory muscles, plus the glottis being closed. Then after, you get the actual ejection phase, ejection of the stomach or the duodenal contents. Once the respiratory airway is covered, then we are free to eject. So in this phase, you have an intense contraction of the abdominal muscles, because you need to squeeze, you need to put pressure on the GIT to pull the vomitus up. This, when it is happening and your LOS or the upper esophageal sphincter is closed, then the vomitus can't pass through the esophagus and outside. So what happens is that as you have intense contraction of the abdominal muscles, at the same time, the sphincters, the esophageal sphincters, will also have to relax to make it easy for the vomitus to pass through them, through the esophagus, through the mouth, and outside the body. And at the end of this phase, you will see the vomitus, the GI content, normally from the stomach or the duodenum, coming through the mouth. So pre-ejection phase, relaxation of forward peristalsis, then backward movement, retroperistalsis, followed by the rhythmic contraction of the respiratory muscles and the closure of the glottis to protect the airway. Then finally, intense abdominal muscle contraction, creating enough pressure to push up the contents. Whilst whatever content that is coming through the esophagus and through the mouth, then the process will be complete. The duration will be prolonged after the main target has been removed, leading to several complications. And therefore, prolonged duration of vomiting can lead to issues like dehydration, electrolyte imbalance, because when the vomitus is coming, it comes out with electrolyte like sodium, potassium, even acid imbalance. Bicarbonate could be lost. That is the natural acid buffer. If you lose bicarbonate without losing the hydrozonium ions, the person could even suffer from acidosis. So dehydration, electrolyte imbalance, pH imbalance, and therefore, at times, even psychosocial issues. Wherever you are always vomiting. You have no other choice than to withdraw yourself from crowd. Find your way somewhere. You don't want to embarrass yourself. So all these complications could happen. And therefore, short-term vomiting may be protective, but long-term vomiting may not be that protective. Now, let's look at what actually goes on within the body to coordinate this act of vomiting in particular. There is a vomiting center within your brain, actually the midbrain. That is where you have a vomiting center. And this will be flanked both left and right side of the vomiting center in the midbrain. Is flanked by the CTZ, which is the chemoreceptor trigger zone. And on the other side, the solitary tract nucleus. Why these? Because these are the areas that can detect the presence of toxins and emetogenic agents and relate the information to the vomiting center, for the vomiting center to also send information to all the muscles, the glands, and whichever other part of the body that takes part in the act of vomiting to start vomiting. So these agents or these areas, CTZ, solitary tract nucleus, will detect the presence of potential agent that can induce vomiting, especially when you have unwanted agents within your body. And after detection, For example, the CTZ and the solitary tract nucleus that lies very close to the main vomiting center in the midbrain stem will relay the information to the vomiting center, and the vomiting center will send efferent input to the respiratory muscles, to the abdominal muscles, to the sphincters for the act of vomiting to occur. Meaning that these centers would have receptors to be able to detect neurotransmitters and other chemicals. Interestingly, the chemoreceptor trigger zone is part of the brain, but it is not covered by the BBB. We all know that the brain is covered by the BBB, but it is not all aspect of the brain that is covered by the BBB. Such areas are called circumventricular areas of the brain. Circumventricular areas of the brain. Simply because this chemoreceptor trigger zone is doing the watchman job. So it is supposed to monitor even the periphery, detect information, and quickly relay the information to the vomiting center for the act of vomiting to occur. So if it is covered by the BBB, then it means the metogenic agent will have to cross the BBB before the chemoreceptor trigger zone could detect it. This will waste a lot of time because we are fighting against time. Imagine if you have a poisonous agent in your GIT. Once it gets into the GIT, absorption begins. If the detection is delayed because it's agent or it's neurotransmitting that transmitters that will have to be released, will have to cross the BBB. By the time the information is sent into the vomiting center, then absorption might have occurred. And therefore, the CTZ, for example, will have to be in close contact with the periphery so that it can easily detect and quickly detect the presence of such emetogenic agent and relay the input to the vomiting center. And therefore, it is very important that it is not covered by the BBB so that it can do constant monitoring, real-time monitoring, detect such input very fast, and inform the vomiting center for the act of vomiting to happen. It is not only these two areas that will detect the presence of emetogenic agents and send the information to the vomiting center. Several other areas, for example, your GIT, there are several receptors there that can also detect the presence of such agent and send the information to the higher centers for the act of vomiting to occur. Even your pharynx, at times you can manually stimulate your pharynx and the information will be sent straight to the vomiting center for the act of vomiting to occur. Even within the renals, even within your testes, all these areas, information can be sent. So most often, it normally happens in football games. When there is painful stimulation of the testes, maybe somebody struck the ball very hard, then it hits your testes. You normally see that that player will be vomiting. That painful stimulation, the information will be sent from your testes to the vomiting center for the act of vomiting to occur. Even from your ears, especially in motion sickness. Some people do board cars, and the moment the cars start moving, they begin to vomit. Even if you are emerging from anesthesia after surgery, if the way they move the bed or the way they move you from the anesthesia bed or the operation bed to the ward is not on point, that movement alone can affect your vestibular apparatus and trigger the act of vomiting, meaning information can be sent just because of the wrong movement to the vomiting center for the act of vomiting to occur. So there are several monitors all around the body that can detect the presence of agents that can stimulate vomiting, be it a painful stimulation, be it a specific toxin, an infectious agent, whatever. There are several areas within the body that can detect such impulses or stimuli and send the information to the vomiting center so that the act of vomiting can occur. Even within the brain itself, the higher center, the cerebrum, which makes it possible for you to think and do so many things. At times, you realize that you are not in contact with anything that can stimulate vomiting, but even the mere thought or the mere remembrance of something that was very appalling, something that wasn't good, it wasn't nice, that alone can stimulate vomiting. And this is taken care of by the cerebral cortex. So in anticipatory vomiting, even the cerebral cortex can send information to the vomiting center for the act of vomiting to occur. As I said, wrong movement, motion sickness, can stimulate the receptors in your vestibular apparatus, mainly histaminergic and muscarinic receptors, and these can inform the vomiting center to spark the act of vomiting. When all these areas send their info to the vomiting center, what happens? The vomiting center will then process this information, and in return, it will send efferent input. So those areas that send the information, they will send afferent or efferent input to the vomiting center, which will process everything. And the vomiting center will also send efferent input to the various glands, the various muscles, be it smooth muscles, striated muscles of the respiratory system, to start the act of vomiting. And therefore, you see that normally the vomiting comes with some saliva, the intense contraction of the smooth muscles, respiratory muscles also taking part, will all be under the command of the vomiting center so that the act of vomiting can occur to get rid of whichever toxin that is occurring. If it's not a toxin and there is any other stimulus that is also doing that, it will still result in the act of vomiting, even though there will be no toxin to be removed. Any question? Class captain, do you have any question before I continue? Somebody has a question. The floor is open. You can ask a question. So in simple terms, there is a champion center in the midbrain stem that control whether you vomit or not. And there are monitors all over your body, your ears, your GIT, test everywhere, including the cerebrum. All these areas can detect the presence of potential harmful agents or any stimulus that can cause vomiting will be detected by some of these areas. The information will be sent to the vomiting center, which will also send efferent input to the muscles, the glands that are involved in the act of vomiting. They will be under the command of the vomiting center. They will obey and contract if they should contract, relax if they should relax. The esophageal sphincters will relax, whilst the respiratory muscles will do their rhythmic contractions. Smooth muscles of the GIT will also do their contractions. This will force the movement of the GI content through the relaxed sphincter with the glottis covered to prevent issues like aspiration pneumonia. And through the mouth, the vomitus comes out. Any question? Class captain.
No, there is no question.
All right. So now, let's look at the specific receptors and therefore the neurotransmitters that can be detected by these various monitors. So that, and in fact, Through this, we can even predict the type of antiemetic agents that we have available and how they work, their mechanism of action. Because if it's a receptor and you have a drug that can block that receptor, that can detect any emetogenic agent, then it means you can use that drug to control vomiting. So let's start with those that flanks the vomiting center. The chemoreceptor trigger zone. The chemoreceptor trigger zone. So the chemoreceptor trigger zone do have receptors for serotonin. So if any input causes the release of serotonin, serotonin can be detected in the blood or even in the cerebrospinal fluid by the chemoreceptor trigger zone, and then it will send the information to the vomiting center to start the act of vomiting. Dopamine is another neurotransmitter that can also induce vomiting, and therefore the CTZ do have receptors in there to detect. Opioids, the mu kappa delta receptors, are also found on the CTZ. Most often when people are given opioids, for example, tramadol, it's normally induce vomiting, and it is the presence of opioidergic receptors on the CTZ that are able to detect, relay the information to the vomiting center and cause problems. Substance P for pain. So if you have any pain, headache, painful testicular vomiting, we have substance P receptors on the CTZ. Histaminergic subtype 1 receptors are also found on the CTZ. So it's not surprising that antihistamines can be used to manage vomiting. Then acetylcholine, remember we said it's also under the autonomic nervous system. Salivation and other secretions are also part. And therefore, if acetylcholine is released, it can also induce vomiting. We have muscarinic receptors in the vestibular apparatus. When these receptors are stimulated by motion, acetylcholine can be released and it can trigger vomiting. CTZ will detect it and relay the information to the vomiting center. So on the CTZ, you have all these receptors that can detect all these chemicals. And all these chemicals are capable of inducing vomiting. And therefore, several drugs, chemicals, toxins, radiations can release some of these neurotransmitters. And when they are released in large amounts, the CTZ can detect them and relay the information to the vomiting center for the act to occur. How about the solitary tract nucleus? It is also rich in receptors for enkephalins. Enkephalins are the natural opioids, together with endorphins and dynorphins. If exogenous opioids can cause vomiting, why not endogenous opioids? So the STN, that is the solitary tract nucleus, do also have receptors for natural opioids like enkephalins. Histamine again, acetylcholine again, and serotonin. So it's becoming clear that the last three, histamine, acetylcholine, and serotonin, are stubborn agents when it comes to the induction of vomiting. And therefore, most of the agents that we use, the pharmacological class of antiemetics, do include some of these agents. So the STN can also detect such agents, relay the information to the vomiting center for the act to occur. In case of the cerebrum, that is the higher cortical centers, that area is stimulated by sight. At times you see something unpleasant and you vomit. That is controlled by the cerebrum. You may smell something that is too hot, too bad, then vomiting will occur. Even the mere thought of something that you have seen before, just normal imagination of that thing can induce vomiting. And emotionally, when you are stressed, in most cases, you will have excessive parasympathetic activation. This can also release a lot of acetylcholine. The whole act will start from the cerebrum. Then that may cause excessive autonomic stimulation, the parasympathetic arm. Acetylcholine is released. Then it is detected by either the STN or the chemoreceptor trigger zone. Then the information is relayed to the vomiting center for the act to occur. How about the periphery? Because the STN, the CTZ, and the cerebrum are all in the brain, the central area. So let's look at outside the brain, because we said there are monitors all outside the brain, all over the body, that do the detection. So for example, in the GIT, you have a lot of receptors there. Serotonergic receptors, substance P is there, muscarinic receptors. Once these receptors are stimulated, then information can be sent from the GIT to the higher centers for the vomiting to occur. Pharynx, your renal, your biliary system, all these areas, and even the vestibular apparatus that I've been mentioning. You have receptors for all these chemicals. And when they are stimulated, information could be sent to the vomiting center for the act to occur. Now, at times, vomiting may occur not because of a single chemical. It may involve several chemicals acting at the same time. For example, maybe serotonin release together with histamine release, or serotonin plus dopamine plus histamine. And therefore, to manage this, a single agent may not be enough. You may have to also counter all of them, all the inputs. So if, let's say, 3 mechanisms are in play, and you have a drug that still have just one action against one of the mechanisms, then you may have to employ other agents to attack each of them. Serotonergic, you attack it. Muscarinic, you attack it. Histaminergic, you attack it. At times too, one single drug may have several mechanisms, and therefore that would be an advantage. So the drug would have maybe a predominant pathway, maybe dopaminergic antagonism. But in addition to that, it may also attack the histaminergic pathway and maybe the muscarinic pathway. In that case, then one agent may be enough. But in most cases, you may have to do a combination therapy. A single agent may not be able to do. And generally, drugs are classified based on the predominant pathway that they attack. So if you have one agent with several mechanisms, especially, let's say, the first generation D2 receptor antagonists, they do have a lot of pathways that they inhibit. And therefore, we say that they have a lot of side effects. When it comes to vomiting, it may be an advantage. But they are classified based on the predominant pathway that they block. The fact that they block, say, the muscarinic pathway, the dopaminergic pathway, you can't classify them that they belong to both. The classification is done based on the predominant pathway that they act. And therefore, for example, the D2 receptor antagonists are classified as such because that is the predominant pathway. It's not to say that they don't have other pathway blockades. They do, but the predominant pathway through which they act is the D2 pathway. And therefore, they are classified as dopamine D2 receptor antagonism. So in summary, several inputs can result in vomiting. And therefore, several pathways will have to be blocked. So antiemetics may have to be used in combination. If you have a single agent that comes with several pathway blockade, then that becomes an advantage. But in most cases, one may have to use combination therapy. Those who have been to oncology, at times you see that before chemo, chemos can cause or induce vomiting a lot, even radiation. You see a combination of antiemetics in, for example, say a serotonin receptor antagonist being combined with a glucocorticoid, and the two will be taken at the same time. Why not one of them? It means that the chemo might induce several pathways to induce the vomiting, and therefore a combination therapy would have to be employed to block most of the pathways. A single drug normally is not enough to be able to counter chemo-induced vomiting, as an example. Class captain, any queries? Any queries? If you have any member with any issue, please allow. Hello, class captain.
So I don't have any question, but if anyone has a question, you can raise your hand.
Okay, so let's continue. Should in case they have, let them raise their hand, then we address it. Now, what are then the types of vomiting? In terms of duration, it could be classified as either acute or chronic. In acute cases, normally it will start, but it won't last more than 24 hours. When it starts and it lasts more than a day, then we say that we have chronic vomiting. So it could be acute or chronic vomiting. In most cases, we see acute vomiting. Chronic vomiting normally goes with chronic conditions, but in most cases, within a very short time, even if you get an infection, for example, from cholera, it may normally be an acute type of vomiting. If it extends above 24 hours, then you are in trouble. Remember, complication goes with the duration. In babies are normally prone to vomiting a lot as compared to adults, with issues like pyloric stenosis, transient opening of the LOS. This happens a lot in babies, and therefore they are prone to vomiting more than their adult counterparts. In babies, they could suffer from post-certain type of vomiting, especially after eating. So the food increases abdominal pressure, or the food may contain a certain toxin or a certain substance that the baby's GIT cannot tolerate, and that can induce vomiting. So vomiting after meals in babies is called post-certain type of vomiting. Then the reflux type can occur. For example, relaxation of the lower esophageal sphincter. Then the projectile one that is normally serious, that is the forceful expulsion of the content. And normally this occurs when they have the pylorus, the area of the stomach that is very close to the duodenum, not moving. And therefore you have stasis within the stomach, building up pressure that can lead to vomiting. So these do occur in babies. But in general, you can classify or chronic, less than 24 hours or above 24 hours. What are some of the issues? Viral infections, bacterial infections, fungal infections. These infectious agents can release toxins that, for example, may irritate your GIT. So it may irritate these receptors within the GIT, and then the GIT will send information to the vomiting center. It can even result in gastritis. So the mere inflammation by the infectious agent could trigger the release of a lot of cytokines, neurotransmitters that may include those that we've mentioned, serotonin, histamine, and what have you. Then the vomiting may occur. If you get food poisoning, as it occurred recently, food poisoning. I never knew food poisoning is the same as somebody putting a poisonous substance in your food for you to die. Food poisoning is food poisoning. Once you get your food being contaminated, loaded with bacteria or microbes, they can get into your GIT, release toxins, and induce the act of vomiting. If you get gastroparesis, for example, suffering from neuropathy in diabetes, this can slow down the movement of your GIT downwards. Once it slows down, stuff will build up in your GIT, increasing your abdominal pressure, and this can induce vomiting. If you overeat, is a sin. Overeating is a sin, and that will make you suffer from vomiting. You have loaded too much, the pressure is too much, you have to throw some up. If you are allergic to certain food substances, or if you are intolerant to certain food substances, once it gets there, it can trigger the act of vomiting. As for medicines, we know a lot of them. High on the list will be anti-cancer agents. And therefore, proud to chemo, we give antiemetic agents to attack. Opioids, once you give them to manage severe pain, can also act on opioidergic receptors, and this can induce vomiting. Migraine is a form of headache, that is pain. Pain can induce vomiting through the release of a lot of neurotransmitters and cytokines. Stress will do same. Stress will do same, also releasing a lot of neurotransmitters. In pregnancy, you have a lot of HCG and human growth factor. This will release a lot of progesterone to maintain pregnancy. All these can cause vomiting. Remember, the developing fetus will also increase the abdominal pressure. This contributes to vomiting, not only vomiting, even reflux. So we implicated pregnancy as one of the causes of GERD, gastro reflux. Gallstones, pancreatitis, appendicitis, all of these can cause pain. And pain, you remember substance P. It is one of the agents that, if it's around, can stimulate and also irritate vomiting. Hangover, you take excess amount of alcohol, you build up a lot of acetaldehyde. This is poisonous. It can induce a lot of neurotransmitters release that can lead to vomiting. So not limited to what you are seeing there, but these are the most common inputs or common agents that may induce vomiting. Several other inputs are there, but at least these are the most common ones that we normally see around. If it's not an infection, it will be pain or alcohol, or pregnancy, and what have you. And all of these, in one way or the other, can affect some of the pathways that normally will lead to vomiting. And of course, the act of vomiting will occur. As we said, if you over vomit for long periods, then it may lead to complications. Dehydration is not surprising because vomitus contains high amount of water. And therefore, if you keep on losing the water, you get dehydrated. The water comes with a lot of electrolytes, notably sodium, potassium will always move out. Then you are in trouble. Remember, bicarbonate may also be lost in excessive amounts that can affect your pH. If this happens, the patient is not going to get any better. The patient condition can worsen from dehydration, electrolyte imbalance, pH changes. And therefore, even if you are due for discharge, we may have to delay, treat, and monitor you. And this goes with a lot of cash. If you are to be discharged today and because of vomiting, we do it next week, you are going to pay. If you have undergone surgery and they've sutured the thing, a lot of pressure that is coming with the vomiting, the intense contraction that comes, it can even put a lot of tension on the suture line. If you are not lucky, it will even open. So the intense contraction that goes with the vomiting can have issues on surgeries. You may bleed if it opens. At times, the contraction itself within the GIT could be so intense that you could even have a tear along the GIT. Then you may bleed. And of course, if you're unlucky and then some passes through the airways, you may suffer from aspiration pneumonia, especially when the patient has altered consciousness. So let's say you've taken a lot of alcohol, it has altered your level of consciousness. If you vomit around that time, and remember, alcohol can induce vomiting, then that coordination may not be on point. The closure of the glottis may not happen well because you have altered consciousness. Some may pass through the airways and you get aspiration pneumonia. Patients who are sedated because they are critically ill and you have to do some interventions. If you have been given anesthesia, you've lost your level of consciousness. All these can put the person at risk of aspiration pneumonia when vomiting occur around these times. So these are some of the complications. If so, then how do we treat? As for vomiting, you will see the person vomiting. So vomiting is diagnosed clinically. You may also gather information as to what the person has taken. Maybe food history, medication history, and that will guide you to be able to predict the possible mechanism, the pathway through which the vomiting is occurring, so that you choose. But it is clinical because you see the person vomiting, and therefore, with the aid of the histories, you can take the appropriate medication or combination of medications to attack it. So what are some of the medications that can be used? Just as we've stated earlier, all those inputs, the pathways, the neurotransmitters that do have a role to play in the stimulation of vomiting could be antagonized. So we pick pharmacologic class of agents that do have antagonism against these pathways. And appropriately, if you're able to pick the right one and it antagonizes that pathway, then the act of vomiting will be cut off. So we have serotonin receptor antagonists. We implicated serotonin, implicated histamine, dopamine, acetylcholine through the muscarinic pathway. Glucocorticoids will act through several pathways at the same time and block most of the pathways. And serotonin as an example. Neurokinin receptors, even cannabinoids. You know, people are arguing that marijuana is a very good agent medically. One of the benefits is an antiemetic effect. So because cannabinoids, when they are released, can induce vomiting. So if you counter this with cannabinoids agents, then you are able to treat vomiting. Then benzodiazepines through their relaxant effect, anti-anxiety effect. When you are anxious, your autonomic nervous system is stimulated. Muscarinic pathways are high up there. So if you are able to relax you and treat your anxiety, then you can be relieved from vomiting. So benzodiazepines through their anti-anxiety pathways can also help us in vomiting. If you are anxious and you vomit, you could be giving benzodiazepines to relax you, and hopefully you'll be relieved. So let's try and then look at the various classes one by one and see what we can do. So in general, this diagram is trying to give us the various pathways and the agent that can be used to cancel those pathways. So for example, if you have painful stimulation, headache, painful stimulation of your testes as an example, anticipatory vomiting under the control of the cerebrum. So seeing something that is not present, you smelling something very bad, emotional factors. This will send afferent input into the higher centers, then all the way to the vomiting center, which will process the thing and send efferent input to the muscles, be it striated, smooth muscles, glands that take part in the act of vomiting for the act to occur. If you are in a car or you are being transported from, let's say, after surgery, and the movement affects your vestibular apparatus, that is when we say that you are suffering from motion sickness. This can affect the receptors, histaminergic and acetylcholine receptors. Histamine or acetylcholine is released from the poor movement. Then they send the input into the CTZ, which also contains a lot of receptors. You remember the huge list of receptors: acetylcholine, histaminergic, dopaminergic, serotonergic. It will detect it and relay the information to the vomiting center for the act of vomiting to occur. If you have endogenous toxins or toxins from infectious agents, this goes into the blood. Remember, the CTZ is circumventricular. It is in direct contact with the periphery, so it can detect toxins in the blood and relay the information to the vomiting center. At times, these endogenous substances, the toxins, can cause the release of agents like serotonin that can start the stimulation all the way from, say, your GIT, the serotonergic receptors there. And the information will be sent to the CTZ, which then relay the information to the vomiting center for the act to occur. If you manually stimulate your pharynx or any other stimulation of the stomach, be it radiation, inflammation, say gastritis, then it is the serotonergic receptors, for example, or the muscarinic receptors in the stomach that will be stimulated. Information is sent into the CTZ, for example, if it is serotonergic or muscarinic. It can also be sent to the solitary tract nucleus through the vagal nerve, muscarinic. Then the two relay the information to the vomiting center again. Then the act of vomiting will occur. So what are the options? So for example, motion sickness, which is mainly under the control of histamine or the muscarinic receptors in your ears. And therefore, we can take antihistamine or muscarinic antagonists to combat motion sickness-induced vomiting. If there are toxins that is causing the release of serotonin, dopamine, then we can take dopamine antagonists or serotonin antagonists. And this is likely going to attack these receptors in the CTZ or even in the GIT, and the vomiting will go. Even in the vomiting center, muscarinic receptors can still work. So these are just almost the same as what we have discussed earlier. There are receptors and therefore neurotransmitters and other chemicals involved. Drugs do act by antagonizing these pathways, and this will cut off the act of vomiting. So let's look at some of the pathway blockades. Serotonergic receptor antagonist. Serotonergic receptor antagonist. The prototype is ondansetron. So all those citron, these are antiemetic agents that will work by antagonizing serotonergic receptors in the CTZ, in the solitary tract nucleus, within the GIT. Serotonin receptors are there, and therefore when you take agents like ondansetron, granisetron, these two are common in Ghana. Granisetron and ondansetron, these are very common. The others are not that common, but at least we have these two, both oral and injectables. All that they do is to block serotonin receptors. They belong to the same class, similar in structure, but there are a few differences. And these differences comes from structural differences. So their chemical structures, and that can affect the affinity for the serotonin receptors. Some will have extensive blockade because they have higher affinity than others. Others are best absorbed, others spread better, all because due to their chemical structures. So, for example, a drug like
Dr. Bobo, please, your network, I can't hear you.
you
Neither,
can't hear
yes,
me.
it's getting like frozen, and the presentation screen that you shared too, I can't hear you.
Oh,
Hello,
okay, but
sir.
but yeah, hello,
Hello.
yeah, hello. But you can see
Hello.
my screen, right? Hello, hello.
Yeah, hello. We can hear you.
You can hear me.
Yeah,
So it's not a general issue.
No,
yeah.
it was from me. Excuse me for interrupting. It was from me. Your voice got frozen, and the screen also got frozen as well. So I couldn't not hear you. Neither was the screen also moving.
Okay, okay. It's okay now.
Yes, please. It's okay now.
All right. Okay.
Thank you.
All right. Okay. So I was on this slide and I said the serotonin receptor antagonists, though they belong to the same class, but there are some slight differences when it comes to their structure. And this normally affects the affinity that they will have for the serotonergic receptor. And of course, their absorption, distribution, metabolism, and elimination. This normally can affect the way they interact with the receptor and therefore can have input on the duration of action. As we said, you have a lot of serotonergic receptors all around, CTZ, the JIT, the STN. So we are not going to talk about that. And therefore, they work when they antagonize the serotonergic receptors in these areas. Now, normally, one interesting thing is that when you take these serotonergic antagonists, even after they are cleared from the bloodstream, you normally see that they are still able to block emesis, simply because in the blood, you may not find them, but at the receptor site, they stay there for quite a long time. And therefore, most of these agents could be used just once a day. Because they have a very long contact with the serotonergic receptors to the extent that even when they are cleared from the bloodstream, because of their persistency, their existence around the serotonergic receptors, they are still able to give you a longer duration of action. So when it comes to their indications, those who have done oncology, you see that ondansetron, garnicitron is being employed a lot in chemotherapy. Anesthesia too, they employ a lot of garnicitron. In females, when they get pregnant, and because of their pregnant hormones, growth hormone, high HCG, high progesterone, inducing excessive vomiting that can lead to dehydration and even ketonuria or hyperketonemia. That is when we say you are having hyperemesis gravidarum, gravida, those terms, gravida 1, parity 1, and whatever. It means that you are pregnant, gravida. So when you are pregnant and you are suffering from extensive, longer durations of vomiting, that is not a good sign because the complications that may come with it will not help the pregnancy. You can use serotonin receptor antagonists. These are safe in pregnancy, can be used to manage it. And you're undergoing radiation therapy that can stimulate the GIT. Serotonergic receptors are there, so you can vomit. Again, ondansetron, garnicitron from this class could be used. One key agent among the group called palonocitron. Palonocitron is able to stay longer than all the other members. And at times, you may get a stimulant an emetogenic agent that will not start the vomiting right away. The time that you don't expect it to work, maybe a day or two later, then the vomiting will come. In that case, if you take palonosetron with its longer half-life, it can help to manage the delayed form of emesis. Emesis that can wait, you take an emetogenic agent, you don't immediately suffer from it, then within a day or two after you have taken the thing, then you start vomiting. If you take palonosetron around the time, because it has a very long half-life, delayed vomiting, like the one that will happen a day or two after you coming into contact with the emetogenic agent, palonosetron, a member of this group, will be there to help you. Now, the next class, those that affect dopamine D2 receptors. Remember, we've mentioned dopamine receptors in the CTZ. So anything that can cause dopamine release can cause a lot of problems. And therefore, these agents are there to help manage. So we have two main classes of the agents that attack the dopamine receptors. First class are also referred to as the prokinetics. When we're doing GERD, gastroesophageal reflux disease, we mentioned prokinetics, metoclopramide, to minimize the regurgitation and the peristalsis. And therefore, if you have an agent that can help induce forward peristalsis, then obviously it will help you avoid vomiting. So prokinetics, metoclopramide, and domperidone. Domperidone is very good when it comes to pedics. So nowadays, we really have suppositories. Domperidone 10 milligrams suppositories that you can give to pedics and even adults. Appropriate. So if you have other options like suppositories and injectables, that will be the most appropriate. If you see any patient who is vomiting in your exam and you recommend an oral agent, you are likely to be marked down because the patient vomiting can't tolerate oral medications. Domperidone is available nowadays in Ghana in suppositories. So you just insert it there, then it works for you. It causes forward peristalsis together with metoclopramide. Then the second group, the antipsychotics. So the antipsychotics, the dopamine D2 receptor antagonists. So chlorperazine, even chlorpromazine, these agents are available. But unfortunately, the first generation agents do have several inputs. For example, in addition to the dopaminergic effects, they also have antihistaminergic effects and anticholinergic effects. With respect to vomiting, is an advantage. Other conditions that we don't want these antihistaminergic and anticholinergic effects, it becomes a disadvantage. And therefore, nowadays, these agents are not preferred in psychiatry. They use the second generation, the quetiapine and whatever, to manage psychosis. But in vomiting, chlorpromazine, prochlorperazine, and other dopamine D2 antipsychotics are well employed in the act of vomiting because in addition to the dopamine D2 blockade, they can also give us histaminergic and cholinergic pathway blockade. But as usual, the worrying problem is the extrapyramidal side effects. The dyskinesia, dystonia, Parkinsonism, and those things, those movement disorders, twitching, and those things are not pleasant. But they are employed in issues when the dopaminergic pathway is part. Then antihistamine. So histaminergic pathways involves your vestibular apparatus, the STN, and the chemoreceptor trigger zone. And therefore, antihistamine sickness. The implicated histamine receptors and histaminergic stimulation in motion sickness. Very common ones include promethazine. We have two salts of promethazine, that is promethazine hydrochloride. The brand name is Finnegan. Then promethazine thioclate, that is albumin. The thioclate is less sedating. It causes less sedation as compared to the HCl. So if you don't want the sedative effect, then you go for the thioclate salt, albumin. That doesn't cause a lot of sedation. In some patients, they say clinically it is devoid of sedation. So that one is preferred by most patients. If you are okay with the sedative effect, maybe you want to sleep, then you may go for the HCl. It is very okay in children and in adults as well. Cyclizine, obviously, is another antihistamine that can be used. And what they do is to what? Block histaminergic receptors, for example, in the vestibular apparatus, the STN, and even the chemoreceptor trigger zone. Main indications, therefore, would include motion sickness and, for example, post-operative nausea and vomiting. Operation causes a lot of vomiting. The moment you keep touching the GIT, you are stimulating pain, and that can trigger vomiting. The anesthetic agents that are used, especially the induction agent, both intravenous induction anesthetics, etomidate, ketamine, inhalational anesthetics, isoflurane, halothane, sevoflurane, all these are emetogenic agents. So together with the surgery itself, operation is a high end or a high factor that can cause vomiting. And therefore, postoperative nausea and vomiting is very high on the list. Histaminergic antagonists can be used to manage post-operative nausea and vomiting. But the problem is sedation, and the older generations like promethazine can also give additional antimuscarinic effect. So the dry mouth and the constipation and those things may also follow. So that is the advantages and disadvantages of antihistamines. Anticholinergics. Anticholinergics, we've been implicating acetylcholine. STN, muscarinic receptors were mentioned. Vestibular apparatus, muscarinic receptors were mentioned. CTZ, it was also mentioned. But of a patch. And this is indicated strongly when it comes to motion sickness. So you have scopolamine patch, that is hyoscine hydrobromide, that is employed in motion sickness. So you put it there about 30 minutes to 1 hour before you take off your journey. By 30 minutes to 1 hour, you may have enough quantities in your blood to suppress the muscarinic receptors in your ears so that when the car starts moving, you don't suffer a lot. Again, it could also be used in post-operative nausea and vomiting. And of course, once you are antagonizing the muscarinic system, be ready to suffer from issues like dry mouth, drowsiness, blurred vision, constipation, and the rest. Any questions so far? Any question? We will finish very soon. This is a very short topic. We'll finish very soon. Vice Captain, any issues?
No, there are no issues.
All right. So glucocorticoids. So one will be surprised why glucocorticoids are being used to manage vomiting. Those who have been to oncology again, you see that patients are being given dexamethasone, 8 milligram, 16 milligram, together with ondansetron or granisetron prior to chemo. So those guys is not surprising. Excuse me. Promo. Please, just a minute. Hello? Hello?
Yeah, hello.
Right. Okay, sorry for the interruption. So, glucocorticoids. So, glucocorticoids, as we always know, work by suppressing several pathways because of the way they work. By inhibiting arachidonic acid, mostly inflammatory agents, several of them are also blocked. And therefore, it works by diverse mechanisms. So it can directly affect the STN and suppress it. Serotonin interactions are there. It suppresses the serotonergic pathway. Neurokinin 1 receptors, it can suppress, as well as opioidergic receptors. And all these are pathways that are implicated in the act of vomiting. So when you give dexamethasone as an example, through these several pathways, it can enhance the blockade of vomiting. And therefore, glucocorticoids are very effective when it comes to the act of vomiting. It can easily block it. So dexamethasone oral preparations are used a lot, especially in oncology for the management of nausea and vomiting. The injectable methylprednisolone can also be used. Unfortunately, you have a lot of side effects. And this normally happens when you give high doses with longer duration. For nausea and vomiting, if you are lucky, you are not going to use it for extensive periods. Just a short time, a day or two, you are done. So we may not face or experience the long-term duration side effects. And therefore, they are highly, highly employed in oncology. You see patients always being given this agent 30 minutes, 1 hour, 2 hours prior to chemo because they have diverse pathways to help us. Then the neurokinin 1 receptors. These are also very, very good agents when it comes to chemotherapy. And therefore, but the only thing is that if you give them as a single agent, they are normally not effective. So they are given in addition to agents like serotonin receptor antagonists or in addition to glucocorticoids. Examples include aprepitant and the prodrug force aprepitant. These agents are also employed in chemotherapy-induced nausea and vomiting. The only thing is that on their own, they are not that effective. But when they are used as adjunctive therapy, together with either glucocorticoids or serotonin receptor antagonists, they become very good agents, especially in oncology. Then the issue, marijuana. So you have active agents in the cannabinoid. These can block the cannabinoid receptors and prevent the act of vomiting. So we have a synthetic one, a synthetic cannabinoid. The structure is almost like the natural active principle in marijuana. It's called nabilon. This is a synthetic cannabinoid, and it's able to block or stimulate, it's able to stimulate the cannabinoid receptor. So it's acting just like marijuana. So people do smoke marijuana and they say that, it has so many therapeutic benefits. Now they should pass it as a law in parliament to allow us to go and freely use marijuana because it doesn't only cause that euphoria and what have you. It has so many therapeutic benefits. One of them is an antiemetic property. Stimulation of the cannabinoid subtype 1 receptors is able to suppress the vomiting center and can relieve us from vomiting. But as usual, if you are taking anything like marijuana, then you should be ready to suffer from the side effects. Euphoria, hallucinations, and at times somnolent. You could even be sedated. These are the bad side. It's not surprising that this agent is not proper, as in popular. It's not normally indicated. I've not even seen it being used in our local setting, probably because of the side effects that it will cause. Then benzodiazepines. Benzodiazepines. This normally is associated with anxiety. So people, for example, prior to surgery, you suffer from a lot of anxiety because you never know what is going to happen. You are anxious, you are thinking too much, and in most individuals, that can stimulate vomiting. People who do fear a lot prior to some performance, they can vomit because of excessive anxiety. And therefore, low doses of benzodiazepines, for example, lorazepam 1 to 2 milligram, could be used to attack anxiety-induced vomiting. Anticipatory vomiting that is controlled by the cerebrum could also be suppressed by the effect of benzodiazepine. So their anti-anxiety effect, amnesia, and sedation, these can help manage vomiting that is caused by anxiety and in anticipatory vomiting. So let's look at specific conditions and the recommended agents that are normally used. So people who suffer from hyperemesis gravidarum in pregnancy, they can use agents like the antihistamines, for example, promethazine thioclate. That doesn't cause a lot of sedation. They can also use the antidopaminergic agents metoclopramide, and the rest can also be used to manage hyperemesis gravidarum. Once they do this, they suffer a lot from excessive dehydration, electrolyte imbalance, and what have you. And in pregnancy, it will not be nice. Even water-soluble vitamins, they tend to lose it a lot. So it's not surprising that at times the excessive vomiting can lead to renal encephalopathy, and therefore you may have to do vitamin B6 supplement. Post-operative nausea and vomiting, a very worrying issue. Imagine you have sutures on it, closing the incision. If you vomit, vomiting comes with excessive contractions. This may even lead to bleeding because the suture site may open, and therefore post-operative nausea and vomiting is not a very good thing. Agents like the serotonin receptor antagonist, the mainstay is granisetron. We have granisetron to attack this. Antidopaminergic agents are there, but we don't use it over there. The main agent that is used in cats, for example, for post-operative nausea and vomiting is granisetron. The motion sickness, the implicated histaminergic and muscarinic pathways. So antihistamine and anti-muscarinic agents can be used. Migraine, very painful type of headache. Headache, you release substance P. So this can cause a lot of problems. Dopaminergic pathway is also stimulated. And therefore, if you are also able to calm the person with the sedative effect of antihistamines, that may also help. So anti-dopaminergic agents, this time we are not looking at the prokinetics, but rather those that works in the brain. So chlorpromazine, prochlorperazine, and the like. These are the agents that can be employed in the migraine-induced vomiting. Then antihistamines with sedative effect, like promethazine, HCl, could also be employed in the management. Cytotoxic chemotherapy, so oncology, receptor antagonists, the aprepitant and phosphaprepitant, these agents could be used. If the agent is likely going to cause the delayed type of vomiting, then remember palonosetron as a very good agent under the serotonin receptor blockade group. In addition to dexamethasone, this combination could help a lot in the delayed type of vomiting. People who are suffering from end-stage conditions and are therefore going through palliative care, they suffer a lot of pain, and therefore opioids are used a lot in palliative care. Remember, opioids will induce vomiting, and therefore, aside their main condition, one of the key drugs that are used in palliative care are opioids for pain management. This will cause a lot of problems. So opioid-induced vomiting, you can use metoclopramide and the other agents that affect dopamine. Remember, opioid can induce constipation. You need prokinetics to do the opposite. So prokinetics can help move the GIT forward and prevent retroperistalsis. Now, if you come into anesthesia, I've been mentioned chemotherapy a lot, so there is no need to go and then hit on chemotherapy. This is mainly due to the radiation and the drugs, the chemos. When it comes to anesthesia, the situation is different. The input or the inducing factors could be the anesthetic agent, it could be the surgery itself, or it could be several other factors that comes into play, the so-called perioperative factors. So let's quickly look at that, then we draw the curtain. So anesthesia-related nausea and vomiting. You guys, you do surgery. I don't know, class captain, are you supposed to do anesthesia in addition to surgery? As in school?
Yeah, I
Your
think so.
syllabus. Hello?
Yeah, hello. I'm not sure,
You are
but
not sure.
yeah.
Yes, please, we are.
But have you been doing anesthesia? Because I haven't seen anybody in CAT being posted to anesthesia. Or you do it when you are at surgery.
Please, at surgery.
So you do anesthesia at surgery.
Yes, please.
How? How do you do it? Do you
We're
have the
just
chance to?
briefly used to the medications, that's all.
So you did not have the chance to go to the theater. Or did you
Um,
see some of the medications?
we went to the theater to witness some of the surgeries with the medications, but there wasn't enough time for us to be properly taught the whole like concepts behind it and the medication.
I don't understand that because we have a whole anesthesia pharmacy. So what prevents them from posting you there maybe once, maybe 1 week or 2 weeks, so that you have a fair chance to familiarize yourself with this thing? It's not as if we have surgery and anesthesia combined as one pharmacy. There is a whole pharmacy for anesthesia and intensive care. Well, all right. Anyway, so let's
Yes.
look at it.
Please, I have a question. So,
Mhm.
in relation to the therapies, when do you decide to stop the antiemetic therapy? So, for example, in pregnancy, when would you?
Oh yeah, so in pregnancy, somebody suffering from hyperemesis gravidarum, maybe 10 times a day, 20 times a day, depending on the type of agent. Every agent do have its own half-life and therefore different dosage regimen. So let's say after giving the last dose, you realize that after the last dose, the patient has not vomited again for let's say over 6 hours or so, and under monitoring, the patient is not vomiting. Eventually, what happens is that it can't just stop abruptly. The frequency will start reducing and eventually everything stops. So you look at the patient, you are doing your normal regimen, let's say you've done 2-3 days, and the frequency of vomiting has reduced or it has stopped altogether. Then there is no need for you to go ahead
Right.
these agents. Remember, your target is to stop the vomiting. Once you give it over, the patient faces the side effect as well. So one key, even in the community pharmacy, one key counseling point that we give is that if you give your last dose and the patient doesn't vomit again, you stop, you don't repeat. Unless maybe you give and the patient vomits, then that one you go according to the regimen based on the half-life. But once you give your last dose and the patient doesn't vomit, there is no need for you to continue giving the. So it depends on the last dose and the last episode. Are you okay?
Yeah.
The
Thanks.
last dose and the last episode. Yeah. So once the patient doesn't vomit again, you don't need to continue. Your target has been achieved. So don't continue. Okay. Any other concern?
Hello, Doc.
Yeah, hello.
Doc, please, I have a question about the antipsychotics. I'm
Mm-hmm.
asking if the atypical antipsychotics can also be used because they don't have the EPSCs that are associated with the first generation antipsychotics. And considering their MOA, they all act on the vitamin D2. So I'm asking in place of the haloperidol and the first generation antipsychotics, can you also employ the atypicals, the second generation antipsychotics
In
in
fact, unfortunately, I've not actually seen the second generations being employed as such, even though the first generations do have a lot of problems, probably because of their non-selectivity. When it comes to vomiting, you would want to take advantage of the additional pathways as well. Other conditions, this will be negative because you don't want other side effects. But in vomiting, Remember, the histaminergic pathway, dopaminergic pathway, cholinergic pathway could all be present at the same time. And therefore, you would prefer the first generation agents that do have non-selectivity as against the second generations that are a bit selective towards the D2 receptors. Are you okay?
Yes.
Any other question? All right, so quickly, we are almost done. So in anesthesia, there are several risk factors that can predispose individuals to vomiting. One of them is the patient, him or herself. The type of surgery that you are going to do, obviously abdominal surgery, laparotomies and the stuff that you are going to touch your GIT and therefore can cause stimulation will have a higher risk of vomiting as compared to, say, orthopedic surgery, where maybe you are working on the limbs or something. Then the anesthetic agent, several of them, especially the general anesthetics, be it the inhalational agent or the injectables, with the exception of propofol, which has an antiemetic effect. All the others, etomidate, ketamine, the inhalational sevoflurane, isoflurane, desflurane, all these can cause vomiting. And the issues surrounding postoperative management, pain management with opioids, movement, or moving the patient, all these issues are possible risk factors that can cause vomiting in the patient. Even before the surgery, anxiety is there, and therefore the patient can suffer. So you can see patient factors. If you ever have a history of post-operative nausea and vomiting, then it is possible that upon your second time or subsequent exposure, you may still vomit. Motion sickness, your movement from maybe the operation bed onto even another bed, or even your transport from the operation room to the normal ward. If it becomes very poor, then it can affect your vestibules, histamine, acetylcholine could be released, and then problems. When it comes to age, obviously children are at risk of vomiting as compared to adults because of possibility of transient LOS realization in them and high rate of pyloric stenosis. Gender, obviously females, especially when they get pregnant, and they have a lot of hormones that can contribute to vomiting than men. And anxiety prior to surgery. Those who smoke, nicotine in a way suppresses the vomiting center. If you don't smoke, then you are at an increased risk of vomiting. So all these are patient factors that can contribute to vomiting. When it comes to the surgery, then the type of surgery, like laparoscopy, as I said, you'll be touching the patient GIT, and that can stimulate irritations and pains, and therefore vomiting. Bowel or gallbladder, again, pain, gynecological surgeries. If you do head surgeries, for example, you are attacking the main center where the vomiting is coordinated. Orchidectomy, if you are going to remove or work on the testes, very painful. Testes, if you touch them, they are very painful. If something hits your testes or your girlfriend or boyfriend touches your testes and squeeze it, probably you are fighting, then you are in trouble. So normally the moment you touches a man's testes, you see that the guy will freeze. He will stay still. He can't move. That is one of our weak points. Very, very, very sensitive to pain. And therefore, anything that can painfully stimulate the testes can lead to the release of a lot of neurotransmitters that can trigger vomiting. Then surgery, that is very long. Yes, laparotomy, when they do exploratory laparotomy, for example, you have a lot of perforations along the GIT. So they don't have exact target. They are just exploring to find where the problem is. That may take a very long time. You touch the GIT, you play with it for a very long time, you increase the possibility of vomiting. The anesthetic agent, induction agents like etomidate, ketamine. Fortunately, propofol is there, which has an antiemetic property. So if an individual is at risk of vomiting because of the person's history, then you can use propofol as the agent. So anybody who is at risk of intra or post-op vomiting, the best agent, if there are no other contraindications to propofol, then the best agent to use will be propofol. So nowadays, propofol, because of several advantages, shorter duration of action and what have you, it is now the first line. Even in sedation in the ICU, propofol is now first line. In anesthesia induction, propofol is first line. Nitrous oxide can also induce vomiting. Then the opioids. Anesthesia, we give a lot of opioids. Yeah, hello?
Doctor, please, how does this NMDA antagonist cause vomiting? Like
Yeah,
how?
they cause a lot of GI irritation. Even when they are injected into the systemic circulation, their widespread effect includes GI irritation. And once you irritate the GIT, you stimulate a lot of receptors, serotonergic receptors, vagal nerves are stimulated, and you are in trouble. So ketamine will cause irritation of the GIT, irritating a lot of nerve endings that can lead to vomiting. Lucky for us, as I said, right.
Yes, please.
So opioids in anesthesia, intra-op, post-op, we use a lot of opioids for pain management. And these can affect opioidergic receptors and induce vomiting. So all of these are possible risk factors surrounding surgery. The surgery itself, patient factors, anesthetic agent factors, all of this can contribute to. And then the perioperative management. For example, if you are being bagged to expel a lot of carbon dioxide, it may cause a lot of gas accumulation within your GIT, leading to gastric distension. That can improve or increase abdominal pressure, and that can induce vomiting. If you get hypotension and dehydration normally will increase the concentration of most of these agents. The mere fact that you are is by what? Weight and volume. So once you lose the solvent and the concentration of these neurotransmitters that are emetogenic increases, it can cause a lot of issues. Spinal anesthesia, you are supposed to do the fourth and the third lumbar. If you enter more than that, you do high spinal anesthesia, it creates a lot of pressure within the cerebrospinal fluid. This can increase ICP, and that can lead to vomiting. It can give you hypotension as well because spinal anesthesia blocks the sympathetic pathway. So those who did anesthesia, you realize that when you are giving the pivocaine in dextrose for spinal anesthesia, normally ephedrine is added to prevent blockade of the sympathetic nervous system. Remember, ephedrine is a mixed sympathetic agonist. It's a mixed sympathetic agonist because on its own, it can stimulate sympathetic receptors. And again, it can also cause the release of endogenous catecholamines, noradrenaline and adrenaline. So it is the best agent to counter spinal anesthesia-induced sympathetic blockade as compared to adrenaline or noradrenaline, because it can do what adrenaline and noradrenaline would do and can also increase the release of endogenous adrenaline and noradrenaline. So 2 in 1. So once you get spinal anesthesia-induced sympathetic blockade, you get hypotension as one of the outcomes. Ephedrine is the drug of choice to manage spinal anesthesia-induced sympathetic blockade. Motion sickness I've been seeing from careless transfer. Patients who are being transferred from operation room to other wards or from the bed, operating bed to other beds. Careless transfer can't cause motion problems and vomiting can be induced from histaminergic and muscarinic pathways. Post-operatively, as I said, you have a lot of pain. In pain, substance P can induce opioids. In surgery, it's about severe pain, so you use opioids. Unfortunately, those agents can also induce vomiting. And when you are asked not to eat, but you eat before surgery, they come, you ask them, have not eaten. Meanwhile, he's lying. If you eat, it increases your GI content. When this induction agent and the surgery itself, they stimulate you. Since you have a lot of loads in your GIT, easily you vomit and you are in trouble. Remember, you are going unconscious. And when you vomit during surgery, you have a higher risk of suffering from aspiration pneumonia. You can even die from asphyxia. The content can even go and block the airways. And if you are not lucky and you are not resuscitated, you could be in trouble. So how do you prevent vomiting surrounding operation, anesthesia, surgery, and all that? So normally it's a multimodal approach: drug therapy, proper patient handling, proper choice of anesthetic agents, and what have you. Remember, we've mentioned hydration and all these. So proper hydration, fasting adequately, at least 8 hours prior to surgery. All these inputs have to be observed. So multimodal approach, including adequate preoperative fasting. Don't eat for 8 hours, please don't eat. You are putting yourself in danger if you eat. Prevent dehydration by doing a lot of effective hydration. So you hydrate your patient well by giving IV fluids. This will not only prevent the patient from suffering from vomiting, but issues like spinal anesthesia-induced hypotension can also be checked by effective hydration. So once you increase the plasma volume of the patient, even anesthesia, because of adequate plasma volume, you are not going to get as in severe drop in cardiac output, because blood volume will increase cardiac output, blood volume will even increase total peripheral resistance. And therefore, you maintain a fairly good mean arterial pressure. Effective hydration is key prior to surgery. Then the selection of the anesthetic technique, which normally goes with the anesthetic agent. So in this case, you choose an agent that has less effect on vomiting. Propofol is an option to take. Avoid excessive mask ventilation. Don't do it over. You are putting in a lot of gas. Some will go through the GIT, causing gastric distension, inducing vomiting. If you have a lot of carbon dioxide in the patient, try to release a lot of carbon dioxide. And especially after laparoscopy. You know, laparotomy itself is a high risk procedure for vomiting. After the surgery, handle the patient well. Do gentle handling. Don't just be moving the patient anyhow because you are rushing to the next case. Then restrict oral intake at least 8 hours before and after surgery. So nil per os, at least 8 hours before surgery, will help to minimize the occurrence of vomiting. Enough on antiemetics. Let's look at emetics. So at times, you may intentionally induce vomiting because, for example, somebody has taken some poisonous agent. And if you don't try to remove them, absorption will occur and the person will be in trouble. This normally goes with time. It goes because you are fighting against time. If you delay, then absorption would occur. So normally 1 hour or 2 hours after the injection, inducing vomiting will be useless because after that time, there will be enough absorption of the toxin. But always make sure that before you induce vomiting, maybe during poison, the poisonous agent is not caustic. Because if somebody has taken something like a very strong acid or a base, and you try to bring it back, it may worsen the person's condition because it will burn the person's upper GIT and even result in strictures. So contraindications to emetics during poisons is when the agent is highly acidic or a highly basic agent, or any agent that has the potential to cause severe burns. You don't induce vomiting. So these agents, emetics, are used to induce vomiting when somebody takes in a potentially harmful agent that you anticipate that it will not be okay for the patient. A typical agent that was there, it's been very long that I saw this agent, ipecacuanha. So syrup of ipeca was the main agent that we used to sell over the counter. Especially when you have a lot of kids in the house, they can ingest anything. So you buy it, you keep it in the house, and should it happen, the person will take it and it will induce vomiting by irritating the GIT. Active principles are two alkaloids known as imetine and cephalide. These are the irritants that are contained in the extract of ipecacuanha. You take it, they irritate nerve endings within the GIT, and in no time the person will throw up. But I've not been seeing it for a very long time. Locally, you can also use emetics like palm oil to also induce vomiting. But be sure that the poisonous agent is not the type that can cause burns, very strong acids and bases, because if you do so, you worsen the person's situation. Any questions? Any questions? Any questions? If you don't have any questions, then I think this is the last slide. Next week, we'll do a more serious business. Yeah, hello?
Yeah, I think Felix Opuku has a question.
Oh, okay. So can you please read it out?
He raised his hand, so
Okay, Felix. Felix. Felix, we are listening.
I think it was a mistake, so you can ignore that.
Okay.
Hello, Doc.
Yeah, hello.
Yeah, please, I wanted to find out if there are any non-pharmacological agents that can be used for the nausea and vomiting.
Non-pharmacological.
Yes, please.
Oh, okay. So normally in pregnancy, that's because of the hormones, HCG, growth factors, and normally you see that they chew certain things like carrots, those other things, but as to whether they have a direct effect in minimizing the vomiting, I'm not sure. But cigarette, but I won't promote cigarette because the harm outweighs the benefit. Those who smoke, they have a very low tendency to vomit. But looking at the harmful effect of nicotine, I will not promote vomiting. But the main issues that we do, the main strategies that we do, for example, in minimizing GERD, could also be employed. Could also be employed in managing excessive vomiting. Anything that increases abdominal pressure can contribute to both GERD and vomiting. So obesity, overeating, if your early you eating at night and what have you, all those strategies will be employed. So when you look at GERD, you can utilize the non-pharmacological inputs, and those ones can help you. But pharmacologically, maybe nicotine. But nicotine may be in therapeutic doses. I don't know about the indication of nicotine that we use in nicotine replacement therapy in nausea and vomiting. I will check on that if that one can be used, but it is not actually used as part of the drug that we use in managing. But generally, smoking, it reduces your risk, but don't go smoking because you want to avoid vomiting. Do the strategies that we do in nausea, in GET, and those at least can help in one way or the other. Are you okay?
Yes, President. Thank
Hello,
you.
sir.
Yeah, hello.
I wanted to find out if activated charcoal also can serve as an antiemetic agent.
Nah. Activated charcoal only helps in absorbing toxins. So it's just trying to minimize the absorption. But when it comes to vomiting, no, I'm not sure activated
Okay.
charcoal can cancel out. Remember, we are dealing with neurotransmitters, nerve ending stimulations. Uh-huh. So I'm not sure activated charcoal can help.
Hello,
Any?
Dr. Bobo.
Yeah, hello. Yes, please.
Please, I can't hear you. Hello, Dr.
Yeah,
Bobo.
hello. Hello.
Hello. Yes. Now,
Papa, I
Dr. Bobo,
think
please, I couldn't hear you for like a minute or so.
So is it a general issue? Can the others hear me?
yeah, we can hear.
So please, maybe with your network. I don't know.
Yes, yes.
Yeah, somebody asked about non-pharmacological means of avoiding vomiting, and the discussion is that those various strategies that are used in GET, non-pharmacological management of GET, could be employed. So reduction of weight, you not engaging in stuff that can relax the LOS. Those 30 meals at night. So if you minimize those agents, then at least it may help. Other than that, vomiting when it starts, it's all about getting adequate agents that you anticipate that when you do, it can stimulate vomiting in you. For example, you know that you are one of those individuals that suffer from motion sickness and you're about to travel and you are going to, as in, use a car or an airplane or something, you make yourself ready. You take these antihistamines or antimuscarinics 30 minutes or 1 hour before you travel. If not, it will happen. The moment the car starts moving, you'll be there. This is still pharmacological. In anesthesia and those things, the various non-pharmacological inputs, appropriate handling of patients, adequate hydration, and all those things could also be considered. Yeah. Any other? Class captain, any announcements?
No,
Hello.
no.
Okay, so next week, I would want us to start the infections. So I think I'll be doing malaria, meningitis, HIV, TB, typhoid. Yes, I have those infectious topics with you. The other lecturers will do the other infectious. Then from infections, we come to respiratory. Respiratory, I'll only do asthma with you. Dr. Attakorah will handle COPD. And the rest. So next week, we will start with infections. Infections, let's begin with malaria that we know already. Let's start from the one that we know them. Very simple ones. Remember just this last year, they brought in new updates. So anything at all can happen. All right. So if there are no more questions, I suggest that we bring an end to today's class. Next week, same time. I hope that the network issues will get resolved so that we can start using our normal Zoom platform, not this one. This one is a bit some way. All right. So finally, any final issue, any final comments before we leave? Okay, all right. So catch you next week, same time. Nice day.
Have a nice day.
Thank you.
Thank you,
Bye.
sir. Bye, sir.
Bye.